Hello, I'm Dr. Erin Mikos, a professor of medicine and associate director of preventive cardiology, and one of our core faculty in our advanced lipid clinic at Johns Hopkins University. Welcome to this special Medscape Live discussion about severe hypertriglyceridemia and what's new in the fight against chylomicronemia. And today, I'm pleased to be joined by Dr. Christy Ballantyne, who is a professor of medicine and the chief of cardiology and cardiovascular research director at Baylor College of Medicine. Now, Dr. Ballantyne was also the lead author of a recent scientific statement published jointly between the National Lipid Association and the American Society for Preventive Cardiology on the recognition and management of persistent chylomicronemia. Christy, welcome to the program.
Thanks, Erin.
So, Christy, before we launch into this publication, I was hoping you could provide us a little background about the statistics for severe hypertriglyceridemia, such as its prevalence in the United States.
Yeah, thanks, Erin. Triglycerides has been such a confusing area. So it is good to start up with definitions. We would say normal or desirable is around less than 150. Moderate is 150 to 499. So that's quite common. That's 26% of the population. Severe is over 500, and most people are between 500 and 1,000. And what's pretty rare is 1,000. And why do we think it's about 1,000? Because those are when people have chylomicron particles. So these big particles, very high triglycerides, usually looks creamy, and that's pretty rare. That's about 0.2%. That was in Haines. We looked at that cross-sectionally. And then we're looking at the Mayo Clinic data. What we saw was that if the people who had persistent chylomicronemia, they really didn't do well. It was 26% of them ended up with acute pancreatitis, 12% with chronic pancreatitis. So it's something that we should all be aware of when you get in this range of 1,000, big risk for pancreatitis.
Yeah. So there's a lot of terms out there, and I was wondering if you could tell us a little about the difference in some of the nomenclature between like severe hypertriglyceridemia, which you're talking about, multifactorial chylomicronemia or MCS, and familial chylomicronemia or FCS.
Yeah, so this is something, and it's, I think sometimes when we get into academics and we want to be more scientific, but we make things pretty complicated. And so, we have familial chylomicronemia syndrome, which is biallelic. We used to say autosomal recessive. You get two defective genes, no LPL activity, extremely high triglycerides, are also very rare. It's about maybe 1 in a million, or maybe it might be 10 in a million, but it's going to be probably more like 1 in 500,000. Multifactorial chylomicronemia syndrome is much more common than this. And these people have very high triglycerides. They do have some LPL activity with it. And it's the most common one that most people are going to see is actually MCS, not FCS.
Yeah, I agree. These names are kind of confusing because FCS is, monogenetic recessive, that they may not have had a family member identified with the condition. And MCS, which is much more common, is likely polygenetic and has this genetic risk. So they may have family members that have, had severe triglyceride disorder. So the names are kind of confusing.
So very confusing with it. I think that was one of the things that comes up is that I don't think it's clinician or patient friendly, because MCS multifactorial kind of implies that it's not genetic. But if many times they have a single pathogenic variant, and they have this polygenic risk score that's high, and so it is genetic. It's very hard for these people to control it with it. So I just don't think we have to make it as complicated as we're making it. There's even clinical scoring systems. It's a little bit like with high cholesterol. Used to be we had the Dutch Lipid Clinic and these different criteria for diagnosing that were quite had to list a whole lot of things, and we made it much simpler. Just what's your LDL? Is there a family history? So I think that was and I appreciate you working with ASPC. Could we do something to make it a little easier for clinicians to understand this? And basically the thought was, as a clinician, if you go in and if someone has a triglyceride over 1,000, and you do the things, and this is really important. Triglycerides, very important to take a good history. Things like obesity, diabetes, alcohol, certain medications, nephrotic syndrome. There's things that are very important to look at. But it turns out, usually, if you address those factors, control the glucose, give some dietary instruction, cut down the alcohol, you're going to have the majority of people. In fact, we saw this that over 90% of them will go below 1,000 and stay below 1,000. And you can use it. We have generic medications. But if they don't, they're very high risk. And so that thought would be like, if you're not able to control them with the traditional approaches, lifestyle and drugs, these people have a high risk. And it turns out some of those people would have genetic FCS. Some of them, we could use a clinical scoring system. And some of them have persistent chylomicronemia, what we might call alarm features. For example, if they've had a history of recurrent acute pancreatitis and they're still over 1,000, boy, that's a high-risk individual. Lots of abdominal pain causing this. If it's an earlier onset where they had it in childhood or young in life with it, if they had post-heparin lipoprotein lipase activity was very low, that's rarely measured now. But in the past, some labs specialized and did that. Those people have an extremely high risk of having an event in 1 year. I mean, some of the trials has been 30% event rates in 1 year with it. But now the other people without alarm features, they still need aggressive treatment, but they're not quite as high of an event rate. But there's still people who we keep an eye on, and you need to try to be working very hard with lifestyle and medications along with treating secondary factors.
Okay, great. So to recap, we felt the need for this scientific statement to help simplify the definitions of persistent chylomicronemia. So we ended up with these 4 groups. So to have persistent chylomicronemia, you needed to have extreme triglycerides above 1,000 milligrams a deciliter in more than half or at least 3 measurements, because chylomicronemia can be intermittent or persistent. So at least 3 measurements above 1,000, and then these 4 groups. So you have the genetically confirmed FCS, you have the FCS diagnosed by the clinical criteria, you have the persistent chylomicronemia with these alarm features such as pancreatitis or hospitalizations for abdominal pain. And then you have the other group of persistent chylomicronemia who do not have alarm features. So they're at high risk, but they're not as very high risk as the other 3 groups. And so with that kind of framework, now we can kind of talk about emerging therapies beyond the lifestyle and the traditional approaches. And novel therapies with apoC-III inhibitors have been considered for these very high-risk groups. So Christy, I was hoping you could tell us first a little background about what is apoC-III, how does it work in lipid metabolism, and how does inhibition of this pathway be a strategy to treat severe hypertriglyceridemia?
So apoC-III, it turns out is these triglyceride particles are useful for carrying basically energy. The triglycerides is how you release fatty acids. The chylomicrons come from the gut. When we absorb, we repackage in these big chylomicron particles. It turns out if you have no LPL activity, you have these extremely high levels. You just don't clear out the chylomicron particles. Now, the people with MCS, actually, they have some activity, but what they usually end up with is they're also producing too many of the VLDL particles. That's the endogenous pathway. And then they have LDL particles. So in a way, the MCS patients also have risk for cardiovascular disease because they have the remnant particles from VLDL and LDL, and they have high ApoB levels. So, it's an important thing. Now, what was fascinating, we knew apoC-III was important in the activity of LPL, but what was really fascinating is that people who basically have no LPL activity, inhibiting apoC-III also reduce chylomicrons. So it has another additional benefit in terms of removing these chylomicron remnant particles and VLDL remnant particles with it. So there's two approaches. One of them is antisense oligonucleotides, and one of them is a small interfering RNA molecule. The ASO has now been approved for FCS, shown to be effective in reducing triglycerides, and then there was a numerical reduction in terms of events for pancreatitis in the BALANCE trial. The second one has been submitted to the FDA, the siRNA. The ASO is called olezarsen. the siRNA. It's called plozasiran. And this one also reduced triglycerides and reduced events. Now, the trials were slightly different in that the olezarsen study, you had to have genetically confirmed FCS. And in the other trial, the trial with plozasiran, it ends up that you had to, you could end up having the clinical confirmation with it. So it's a little bit different for that.
Yeah, I admit I was surprised before I saw this data. I didn't realize, how much apoC-III inhibition can be working through non-LPL, pathways, because these FCS patients have really no functional LPL at all. But in these trials, as you mentioned, Palisades enrolled patients with both genetic FCS and clinical FCS. And was the triglyceride lowering about the same in those groups that had both genetically confirmed or clinical FCS?
So it ends up successful in both groups. There might be a little bit better reduction in the people who have, basically clinical criteria with it. And the other one in plozasiran, there were some that just had these alarm features. They just had persistent chylomicronemia with alarm features. But it was beneficial in the event rates in the group that didn't have the genetic confirmation in the Palisade trial. It was 20% versus 30%. That's an alarming event rate. I mean, you never have a cardiovascular trial with 20% events in 1 year. So they were a very high-risk group of individuals. So I do think it's something where I liked that the FDA actually said, go ahead and allow people in who are very high risk, because we want to see how the drug works in that group also. So I think it's something where it's having a pragmatic approach is important. Genetics it's great, but not everybody can get genetic testing, as you know. And so being able to make a clinical diagnosis and identify who's needs this, it would be, I think, reasonable to refer to a lipidologist. At this point, these are, it's just pretty severe disorder. So the additional expertise of the lipid clinic would be beneficial.
Right. Yeah, I just want to underscore, how bad pancreatitis is. It's certainly a condition that has significant morbidity and mortality. And once a patient has pancreatitis, they're at increased risk of getting it again, even at lower triglyceride thresholds. And I think was really remarkable in plozasiran trial, the Palisade trial, that plozasiran reduced acute pancreatitis have a functional LPL, so they have very poor response to have our traditional approaches, and to have something that we could offer patients going forward that can significantly reduce pancreatitis risk. I think it's really a game changer in this lipid field.
Yeah, I agree with you completely, Erin. It's really exciting. Having had people who are in the—
seem to have lost your audio, Christy.
Strange.
But I was also hoping to talk about that these initial trials were an FCS. And as we began with this statement, there are patients who have MCS or persistent chylomicronemia with alarm features that likely also would benefit from these novel therapies.
Yeah, so can you hear me now, Erin? Can you hear me?
All right.
They can hear me anyway. Maybe you're not able to, but they can hear me. So it's really exciting news. We could never treat these patients. And so we now have a therapy for people who have FCS. So and hopefully we'll get more and more data about this. Trials going on for severe high triglycerides with these agents. But it is something, be aware of it. When you see chylomicronemia over 1,000, it's a big issue. They need special attention and follow up in regard to lifestyle, drug therapy. And if they don't respond, get a lipidologist involved, because they may need these new therapies.
Well, unfortunately, we're out of time. I don't know if my audio has come back, but we could talk about this interesting topic all day. So very exciting advances in the field that can help our high-risk patients with severe hypertriglyceridemia, and very timely consensus document that you led, Christy. So thank you, Christy, for being part of this program.
Thanks, Erin. And thanks for your help on the document.